Respected members of the board of the Urology Society of India, respected medical superintendent sir, respected pro vice chancellor, and the fellow members and delegates present here, ladies and gentlemen. I would like to welcome you all to the inauguration ceremony of LUTD 2019. Just as culture plays a main role in our lives today, we cannot begin any ceremony without the ceremonial lighting of the lamp. So I would like to call upon the President-elect of the Urology Society of India, Dr. Anant Kumar, the Secretary of Urology Society of India, Dr. Rajiv TP, the International Guest Faculty, Professor Paul Abrahams, the Board of Education Urology Society of India Chairman, Dr. Anish Srivastava, the Chief Guest, Pro Vice Chancellor, Health Sciences, MAHE, Dr. Purnima Baliga, the Guest of Honor, Medical Superintendent, Dr. Anish Shetty, and the Program Coordinator, Dr. Arun Chawla, to light the ceremonial lamp. I would like to request the dignitaries to take their seat on the dais. Now, to begin the proceedings in the name of the Almighty, we have our very own student Ananya to present us with a melodious prayer song.
Mahagadapatim manasa smarami Mahagadapatim Mahagadapatim manasa smarami Vashishta Vamadevadi Vandita Mahagadapatim Mahadevasutam Guru Guhanutam Mahadevasutam Guru Guhanutam Marakoti Prakasham Shantam Mahakavinattakadi Priyam Mushakvahana Modaka Priyam Mahagadapatim Mahagadapatim manasa smarami Mahagadapatim manasa smarami Vashishta Vamadevadi Vandita Mahagadapatim.
Thank you, Ananya. Now, to welcome the gathering, I would like to request the Board of Education Urology Society of India Chairman, Dr. Anish Srivastava, to present the welcome address.
Good afternoon, everyone. Dignitaries on and off the dais, faculty members from all over the country, delegates and students. It is my pleasure to welcome you all for this 3-day event in this city of Manipal. See, I have an old association with this city right from 2000. I think I was coming here as an examiner. Then I came here for the historical increase of seat from 1 to 2. That was in 2010 when there were a lot of issues, and I think out of many departments, urology was the one where they listened to my opinion, and the seat was increased from 1 to 2. In many other departments, I think that was not done. So my association is long. And about this event, actually, peculiarity, there are two unique things which I would like to mention, that this is the third BOE or Board of Education activity by the department in Manipal. So I think that's a very unique thing. And the second unique thing is this Bristol USI Urodynamic course, which is being done by actually as a first ever course in the history of Urological Society of India, where we have advertised and then we have taken 20 young consultants who are being trained by Professor Paul Abraham. So he is the anchor, needs an applaud and actually a standing ovation to him for bringing something very unique to our society. Dr. Paul Abraham. So we had the certificate course yesterday, and now we have this 2-day event, and as you are seeing right from the beginning, he has set up the momentum in a very different way, and all of you are going to learn a lot from him. And secondly, from all the eminent national faculty members, Dr. Sabnis, Dr. Nagaraj, Dr. Sanjay Sinha, Dr. Uttam, Professor Venu Gopal, Dr. Nitin Kekre, Dr. Venkat, and Dr. Anant and some others. So I think I should thank them on behalf of the Urological Society of India and BOE for having spent their valuable time with us for these 2 days. And then I think I should thank Dr. Chawla and the team, entire team, Dr. Joseph Thomas and everyone from the Department of Urology, because they have been working hard to see this day together. And at the end, I would just mention to the Pro Vice Chancellor and others about the Board of Education. Through this, which is a part of the Urological Society of India, is more or less an independent body, and we do about 20 such academic activities in a year. And the main activities are the education to the postgraduates, giving them mock examination practice. For the younger consultants, the CMEs and operative workshops are being held. Then we have the MOUs with the BOUS, with the AUA, with the Singapore Society, with Nepal Society, and with the Asian Urology Society. So we take an exam once in a year, and through that 17 postgraduates are sent to different conferences abroad. First 4 generally opt for the AUA, and then for the BOUS, for the EAU, and like that. So these are the activities done by the Board of the Education. And I think with that, I again thank all of you once again to have come here, made this a successful event. Thank you very much.
Thank you, sir, for those kind words. Now I would like to call upon the President-elect Urology Society of India to address the gathering.
Honorable Chief Guest, Pro VC Dr. Baliga, our Guest of Honor Dr. Shetty, our Senior Most Urologist Professor Venugopal, Professor Paul Abraham, TP Anish, and other senior members of the colleague and friends and colleague. On the behalf of USI, I welcome you all for this LUD 2019. And I would like to say a few things about, first thing about in 1988, when we joined, 1987 we joined Sanjay Gandhi, we bought the video urodynamic machine, but we have no idea. So I was sent for the training, and I went to Bristol. There was a small hospital, Ham Green Hospital. I hope it doesn't exist now. And I had first urodynamics course with Professor Paul Abraham. I think that I remember the date, it was 29th March 1988, and when I got the first idea of urodynamics. And then we came back, and with the help of Anish and other colleague and Sanjay will remember, initially we struggled, but we did establish very good urodynamics unit, because we had the foundation stone by you, and we initially published 5 papers in all international journals. So that's what the beginning of urodynamics, and we understood it. So first thing is the training is very important thing. And as you said, the 3 things about education. When Sanjay Gandhi Postgraduate Institute started, they put 3 aim: education, training and research. And they said that if you can achieve all 3, we can improve the quality of all human being. And third thing is that the Board of Education, when it started, I was the first one to take the lead, and we thought of a lot of things. And the first thing which became very popular is the mock examination, and few other things which slowly started coming. And I am very happy to see that Board of Education nowadays is doing so much training and education for our young urologists that it is very good. Now he just told me that there are 20 courses and training program, and there are different types of training program like skill programs and simulation programs and hand-on training program and cadaveric program. So that is a very good thing to train not only young urologists, but like today sitting in this, when Prof. Paul Abraham was telling it and asking many questions, we learned a lot of other things. So we learned from our juniors, we learned from our colleagues, and learning is always ongoing process. So we love to attend these courses even in whatever stage we are to improve our training. With that, I welcome you all again and for this course, and we hope that all will be benefited and go and provide better health care to our patients. Thank you.
Thank you, sir, for sharing your thoughts and enlightening us. Now I would like to call the Secretary of the Urology Society of India, Dr. Rajiv TP, to address the gathering.
Avinash Shetty, the Medical Superintendent, Manipal Medical College Hospital. President-elect Professor Anand Kumar, eminent international faculty from Bristol Urological Institute, Professor Paul Abrahams, BOE USI Chairman, Professor Anish Srivatsav, Organizing Secretary, Dr. Arun Chawla, Senior Teacher, Professor P. Venugopal, my seniors, colleagues, and student friends, ladies and gentlemen. First of all, greetings from Urological Society of India. It was indeed a good arrangement by the Department of Urology and Renal Transplantation, Manipal, Kasturba Medical College, Manipal. This is the third BOE USI program after the first one at STPGI Lucknow and the first mock examination at BT Savani Hospital, Rajkot. And this is the first ever course on neurodynamics conducted by the USI. And yesterday I was an attendee to this program, and it was a wonderful course on basics in neurodynamics conducted by none other than the eminent faculty, Professor Paul Abrahams. And it was attended by 23 young urologists from across the country. And I don't have any doubt that all of them have been benefited by this wonderful program. And again, from today onwards, there is a CME on lower urinary tract dysfunction is being organized, and you have seen in the first half in the morning, it is a wonderful discussions going on various aspects of lower urinary tract dysfunction. And it is indeed a pleasure to note that there have been good interaction from the floor as well. The Board of Education USI has been putting in a lot of efforts year after year to improve the academic activities of USI. And this year, as the Board of Education Chairman has highlighted, there is a line of academic events this current year tuning to around 18 to 20. And the only thing I had to request from the young urologists and the trainees that they should utilize this opportunity, attend most of the BOE programs as far as possible, because this is basically intended for the young urologists and the trainees. And Board of Education and USI is putting in a lot of pain in this so that it should be fully utilized and take the maximum benefits out of this. And I once again extend on behalf of USI all the participants in this program and extend thanks once again. Thank you once again. And last of all, my sincere thanks to the staff of Department of Urology and Renal Transplantation, Kasturba Medical College Hospital, for making such a fabulous arrangement for this program. Thank you once again.
Thank you, sir. Now I would like to call upon our chief guest, the Pro Vice Chancellor, Health Sciences Mahe, and the ever cheerful, supportive and enigmatic Dr. Purnika Baliga to address the gathering.
A very good morning and afternoon to all the eminent urologists around. I think this is a very concentrated audience speaking all about urology and field of LUTD. The Department of Urology, if I can speak a little bit of KMC Manipal working in Kasturba Hospital, has always been conducting wonderful, well-organized academic programs, and it's a feast to see them organizing. And I think masters in that, and they get faculty coming from all over the globe with a targeted audience, and the speaker is the best in that particular subject whenever they get. So in a medical school, when they have postgraduates with them, I think the moral responsibility is to teach and to make sure that the postgraduates who get out of the portal of the medical school are well trained and make a name for themselves and in the field of their subject. And to that extent, this department has been doing a wonderful job of imparting a lot of knowledge by getting wonderful speakers. And as Dr. Srivastava put it, education is the most important pillar in any educational institution, and with the institution of eminent status that is given to Manipal Academy of Higher Education, we have 5 pillars on which we have been working. One is excellence in education, the first pillar. The second pillar we put as excellence in research. So we have taken 2 important pillars. Other one, internationalization. This is a perfect pillar that we have today on internationalization. For education, the person coming from outside India. Excellent educational initiative here. I think the research the department is doing wonderfully well. And alumni engagement is very important. I can see Venki sitting there. He is the distinguished alumnus. And Jishan is a faculty here. He is also another alumnus. So I think 4 pillars are already met with. And enabling foundation, that is coming out with the infrastructure which they have already. So I'm very happy to note that all 5 pillars have come so together beautifully well, and this program is centered around that. And sir, for your information, from 1 to 2 you had made, I'm proud to tell that they have gone from 3 to 6. So please congratulate the Department of Urology on recently getting an increase in the number of seats from 3 to 6. And I had a opportunity to speak to the inspector who had come, and I wanted to just say hello to him and a courtesy visit. I was talking, he said, "Madam, this department is very well organized, and I have no doubt in my mind that this increase in the number of seats is going to help the postgraduates." And also he complimented, he said, "Your office manager is excellent. He knows everything about MCI and is doing so perfect a document," which is very rare to find in medical colleges. And I was very happy that, a positive comment made, and I appreciated that. I called up the office manager. I said, "I congratulate you. MCI SSR has appreciated you." I think to that level, this department has been functioning, and I know they have organized this function also. I have no doubt in my mind this is going to definitely help the well-established urologists and the budding ones in getting more knowledge about whatever you are discussing in the next yesterday and today. And it's also important that we remember, in education, if we don't update ourselves, we become obsolete. What is right today is proved wrong tomorrow. So every day we need to update, and I think in that the BOE urology is doing really, really well. And I think they even had a mock exam at a national level that was conducted 2 years back. 16, yes. They did conduct, and it was a wonderful thing to see. I was very impressed. So I think BOE, this is the only society, I think, urology, very active people. They have a lot of educational activities. I have not seen any other societies that are doing so much of work, or maybe we are not aware of, which is not happening in. If they were doing it, I'm sure Manipal KMC would have had a good number of them. But urology is always active, and congratulations to the Urology Society and the BOE Urology. Please continue to do this good work. Make sure that the products that come out of any medical school in India are the best, and they make India proud when they go abroad. All the best. Have a good day. Thank you.
Thank you, ma'am, for those kind words and words of wisdom. Now, last but not the least, I would like to call upon the Program Coordinator of LUTD 2019, the Chairman-elect of the Board of Education, Urology Society of India, and the Professor and Head of the Department of Urology, KMC Manipal, Dr. Arun Chawla, to deliver the vote of thanks.
Good afternoon, everybody. Before I propose the vote of thanks, on behalf of Department of Urology and MAHE and Board of Education USI, I have privilege of honoring the star of whole program, our international faculty, Professor Paul Abrahams. And before we felicitate him, a few words of introduction. Professor Paul Abraham is Professor of Urology at University of Bristol and Head of Teaching and Research at Bristol Urological Institute at Southmead Hospital. He is a consultant urological surgeon at North Bristol NHS Trust. He has been chair of international consultation on urological diseases since 2008. He is considered one of the world's leading experts in the field of lower urinary tract dysfunction. He is particularly interested in benign prostate diseases, female and functional urology, neurourology, and urodynamics. An author of 400 peer-reviewed journal articles, numerous chapters in the books, more than 100 invited articles, Professor Paul Abraham has edited more than 20 books. He is responsible for the introduction of term lower urinary tract symptoms with Ellen Wien and the term overactive bladder. He has received number of awards and honors: Spence Medal from August, St. Peter's Medal from Bos, Willy Grigor Medal from EAU, and in addition, Lifetime Achievement Award from ICS and SUFU, and the Distinguished SAU Career Award. With these few words, may I request the chief guest of today's program, Pro Vice Chancellor, MAHE, Dr. Purnima Baliga, to felicitate our international guest faculty. Thank you, ma'am. It's indeed a privilege and honor on behalf of Department of Urology and BOE USI to propose the vote of thanks. At the outset, our gratitude and hearty thanks to the chief guest of today's program, Pro Vice Chancellor MAHE, Health Sciences, Dr. Purnima Baliga, for accepting the invite for this program, and also for providing the motivational, inspirational support to carry out different academic programs in our department. We thank you, madam, for your stewardship, vision, commitment, and continuous support to us. Thank you, ma'am. Our sincere thanks to guest of honor, our young and dynamic medical superintendent, Kasturba Hospital Manipal, Dr. Avinash Shetty, for being a part of this program. As a head of this hospital, he has facilitated the purchase of a new urodynamic equipment for our department, which is going to be installed shortly. We thank you, sir. Our hearty gratitude to President-elect USI, Dr. Anand Kumar, and Honorary Secretary USI, Dr. Rajeev TP, for sparing their valuable time to be part of this academic program. You have been here during our last Southern Annual Conference, and I hope you will be gracing this occasion during our future events too. Thank you, sir. We are grateful to Chairman BOE USI, Dr. Anish Srivastava, for giving us the opportunity to host this program. We know that you have an old bonding with Department of Urology in particular. You have come here as examiner, as a MCA inspector, and your son Abhinav did his engineering from MIT Manipal. We thank you, sir. We are extremely grateful to Professor Venugopal, teacher of teachers and founder of this department. He has braved his sickness. He was sick last week, but still he has made a point to come here, and he has come here to bless with his gracious presence. We thank you, sir, very much. A heartfelt thank to Dr. Sanjay Sinha, Hyderabad, Dr. Nitin Kekde, CMC Vellore, Dr. Sabnis Nadiad, and Dr. Venkatesh Krishnamurthy, Bangalore, for their unstinted support, for the guidance, valuable contribution, and encouragement to our program. I thank all the distinguished invitees, chairpersons, and panelists for accepting our invite and attend this program. Our sincere thanks to all the delegates who have come from different places. Thanks to Dean KMC, Dr. Pragna Rao, and the Office of KMC for helping us to organize the program in this venue. We owe a special thank to Colonel Prakash, Director General Services, MAHE, Mr. Bangera, Mr. Jay Vital, and other office bearer of MAHE for their support in organizing this program. My hearty thanks to my department colleagues, Dr. Joseph Thomas, Dr. Padmaraj Hegde, and my colleague from KMC Mangalore, Department of Urology, Dr. Lakshman Prabhu, for their constant guidance and motivation in organizing this program. Last but not the least, my words are not enough to wish a heartfelt thanks and special gratitude to the main star of this 3-day program, Professor Paul Abrahams, and I hope you are having a wonderful stay. Once again, I thank you, one and all.
We see these relatively regularly, so that does seem that some drugs can cause detrusor underactivity. Then failure to get your bladder to contract may be a result of your urethral sphincter or your pelvic floor not relaxing. And of course, the micturition reflex depends on urethral relaxation followed by detrusor contraction. So if your urethra doesn't relax, your detrusor contraction may be inhibited. And we see that in idiopathic urinary retention. And then, of course, there's lots of neurological causes that may lead to detrusor underactivity. So we see multiple sclerosis quite frequently, a condition that you don't often see. But of course, you see stroke, and stroke in the dominant hemisphere is associated with detrusor underactivity and detrusor overactivity, confusingly. So as I say, our knowledge is imperfect. Now, this is a survey done amongst Indian urologists last year by Sun Pharma, and they asked, I think, 500 urologists in India, what is the percentage of patients in your clinical practice presenting with underactive bladder due to these causes? So they gave them these choices and asked which are the commonest. And as came up in the discussion earlier, diabetes is obviously more of a problem in India than we see in Britain. So diabetes and neurological were the commonest, followed by post-surgical, postpartum, and bladder outlet obstruction. Now, if we look at the symptoms, and this is quite a large study, comes from quite a large study, it's looking at detrusor underactivity patients in blue, pure detrusor underactivity, and then age-matched patients with detrusor underactivity and a coexisting condition which might be detrusor overactivity, because remember you can have detrusor underactivity during filling and detrusor overactivity during filling and detrusor underactivity during voiding, or it may have been coexisting outlet obstruction. And you can see there isn't very much differentiation between the symptoms and the conditions, meaning that it looks as if it's going to be difficult for us to distinguish patients with detrusor underactivity without doing urodynamics, which is not totally satisfactory because it then means it's difficult to pick patients for treatment, for targeted treatment by drugs in particular. So why is detrusor underactivity important? Well, it's prevalent, as I'll show you. It's important in the differential diagnosis in both men and women who have voiding dysfunction. In men, it's a significant cause of poor outcome after TURP for LUTS, and in women, it's associated with poor bladder emptying and urinary infection. We have to remember that in the aging population, a lot is changing in lower urinary tract dysfunction. So LUTS is increasing with age. In the male population, prostatic enlargement leading to obstruction is increasing with age. In both sexes, detrusor overactivity causing overactive bladder is increasing with age, and detrusor underactivity causing voiding symptoms is increasing with age. And on top of that, we have the causes of nocturnal polyuria, largely around balancing fluid in older people, and that increases with age. So there's a lot going on, potentially, with the lower urinary tract as you get older. Now, if you look at the literature, it's not entirely clear. So what's the prevalence of detrusor underactivity? Well, that can only really come from urodynamic series of patients. There are no randomized controlled trials, there are no prevalence surveys where they find people with symptoms and invite them to come in and have urodynamics. So these are people who turn up in the urodynamic unit with symptoms and have urodynamics. But it remains true to say that if the patient is very elderly, then detrusor underactivity becomes more common. And this is work from America in institutionalized elderly people, most of whom, of course, are women, because women live longer than men. And as I've said, it's a contributory factor after prostate surgery in 30% of men, causing the man to be unsatisfied with the results of the surgery. So these are the series, and these are urodynamic study populations. And you can see the percentages, 17, 10, here's the one of 48, which was in men, here's one in women, which is about 18 to 20. So it's variable, the percentages, and one reason will be is that we don't have a precise definition of detrusor underactivity in women. So those women can't really be adequately categorized without a definition. In men, of course, we have the bladder contractility index, and this is derived from the same group of patients that we derive the bladder outlet obstruction index, where, of course, you have a large number of people with a condition, prostatic obstruction. You have a good operation with a good outcome. So you can take the preoperative population and see what the outcome was like, and you can define obstruction and contractility in those terms. In women, of course, certainly obstruction is very unusual. It's only about 4% of the urodynamic population, whereas in men, 50% of our men are obstructed. So it's very difficult to derive either contractility nomograms or obstruction nomograms in women. But in men, we do have a nomogram which we trust, which is the contractility nomogram, which we mentioned earlier, and that is the bladder contractility index equals PDEC Qmax plus 5 Qmax. And this is the diagram I showed you earlier. High pressure, high flow is a strong bladder. Low pressure, low flow is a weak bladder. Pressure on the vertical axis and flow rate on the horizontal axis. The other concept which we didn't mention earlier, but we did talk about post-void residual, I think bladder voiding efficiency is more useful than what's the post-void residual, because of course what's the post-void residual has a completely different significance according to the bladder volume. So if you have a bladder volume of 200, a 100 ml residual urine reduces your voiding efficiency to only 50%. On the other hand, if you have a bladder capacity of 500 and you void 400, you have an 80% voiding efficiency. If you do a TURP on somebody who's obstructed and you get rid of their residual urine, if their bladder volume was 200 with 100 residual, you will halve their frequency. So if they were going 10 times a day, they will then go 5 times a day. If, on the other hand, their bladder capacity is 500 and they can already void 400, you will make hardly any difference to their voiding frequency. So in clinical terms, it's much more useful to talk about bladder voiding efficiency, which is just the percentage of the bladder volume that you void. So it's the voided volume divided by the voided volume plus the post-void residual times 100, giving you a percent. So I've said it's important in the outcome of TURP patients. And what about this patient? Well, this is a man who voided 150 ml, leaving 100 ml in his bladder. And you can see he has a fluctuating flow with a maximum flow rate of 8 ml per second. So would you do a TURP on this evidence? 8 ml per second, voided 150, 100 left behind. Well, I think most people would do a TURP on that basis. But remember, Professor Nikri said this morning, you only have a 70% chance of being correct that this is obstruction. In other words, you have a 30% chance of being wrong. So despite us knowing that there's a 30% chance of being wrong, most of us do a TURP in this situation. So here is the pressure flow. So I've uncovered the pressure flow. Red for rectum, blue for bladder, detrusor. You can see there's no straining. It's a good quality trace, so we can trust the measurements. So what we're interested now, obviously, is in the relationship between the maximum flow and the pressure at maximum flow, because that will allow us to derive the obstruction index and the contractility index. So these are the two figures we get. So with a maximum flow rate of 8, the pressure, the detrusor pressure at maximum flow is 31. So what does this mean? Well, we can use our indices, as I've mentioned. And here is, firstly, is the man obstructed. So you remember the figures were 8 and 31. So this man is within the unobstructed range. So this flow rate, which didn't look at all good, is not indicative of obstruction. So why has he got a low flow? Well, if we put him into the contractility nomogram, still with his 31 and his 8, we see that he has a weak bladder. So the issue with him is he's not obstructed because his BOOI is below 20, 15, and that's normal. He does have detrusor underactivity because his BCI is 71 and the normality begins at 100. So his low flow is due to detrusor underactivity and not to bladder outlet obstruction. So we have to decide then what we do about him. And the available literature would say that detrusor underactivity patients do not do well from TURP. So you have a problem in that the bothersome LUTs may not be anything to do with bladder outlet obstruction, even though they are the symptoms we classically said were related to obstruction. And they may be responsible for persistent voiding problems. Detrusor underactivity may be responsible for persisting voiding symptoms after TURP. So this case here is a particularly worrying case. So this is somebody who was sent to us from another place, and he is really young. He's only 45, and he's already had a bladder neck incision for poor stream. So what do we see? Here's the filling phase. He's got some leakage here for some reason or other, which begs the question as to whether they damaged his sphincter. But this is the voiding phase. There's a lot of interference here, and the interference is probably because he's moving around. If we look at his blue for bladder, red for rectum, we can see that he's straining repeatedly to try and empty his bladder. And he's got an intermediate flow. So this man has probably never been obstructed. He didn't have urodynamics prior to his bladder neck incision. And of course, I think that is wrong. And this man, I'm sure, could have taken legal action against the hospital that went ahead and did this procedure, because not only have they not improved him, of course they've risked his sexual function in the state that he has some degree of retrograde ejaculation. He doesn't ejaculate as well as he did before. So I think that's why it's a bit disappointing that the EAU guidelines don't mandate doing pressure flow studies prior to invasive therapy for younger men, because of course the chances of them having detrusor underactivity is much higher than the chances of them having prostatic obstruction. So, as we said earlier, why do urodynamics before every prostatectomy? Well, because as we can see, there are no diagnostic symptoms for obstruction. In fact, the symptoms for obstruction and for detrusor underactivity are pretty similar. There are no signs, of course, for prostatic obstruction. By that I mean X-rays or anything else you can do. Urine flow studies are unable to distinguish detrusor underactivity from prostatic obstruction as a cause of both low flow and residual urine. So only pressure flow studies can find the patient that you want to operate, which is of course the man with true obstruction. And of course surgery is designed to relieve prostatic obstruction. And I think if we put ourselves into the shoes of patients when they're coming up for an operation, what they want to know is, are they the average patient? So if it's a good operation, the average patient's going to do well. And they would like to know whether there are any factors in them which mean they might not get a good result from the operation, because some patients will then decide not to have the operation. So properly informed consent for a procedure that's not for cancer is really important. So if we're talking about prostate surgery, the man will think, will I do less well than the average person who has surgery on the prostate? And the answer is yes, you will do less well if you're not obstructed, if you have significant pre-operative overactive bladder and detrusor overactivity, as we discussed this morning, that may persist, if you have detrusor underactivity, and of course, if you're not obstructed, you may get worse, because you may be in the 5% of men that get either a stricture or who are made incontinent due to sphincter damage. So precise diagnosis is, of course, as always, very important. So whilst we have published data showing that you have a 90% ability to predict obstruction if the flow rate is less than 10, both the EAU and the AUA, when they do a meta-analysis, put the figure at 70%. And that is because we do flow rates better than the average place. And the reason for that is we set up a flow clinic. So we know that the patient will do good flow rates. If you just do flow rates in an ordinary clinic, then your predictive value of flows is not as good as 90%. It's down around 70%. So what happens to these patients with detrusor underactivity if you don't do anything to them? Or if you do something to them? So we had a very industrious young man working with us, Alan Thomas, and he followed up about 400 men with LUTS, who we had done urodynamics on 10 years or more previously. And he invited them to come back in and have repeat urodynamics. So the minimum interval was 10 years, and this is the longest follow-up in the world literature. And that's not surprising, really, is it? Because it was a mammoth effort and probably couldn't be done these days. So what he found was that the natural history of detrusor underactivity after TURP, so this group of men with detrusor underactivity elected to have a TURP, or the surgeon persuaded them, one or other, and there were no significant improvements after surgery to their voiding in terms of flow, pressure, or post-void residual. The TURP made no difference. This group of patients were untreated, again with a minimum of 10-year follow-up. So they decided they didn't want to do surgery, and the findings were that there was no significant deterioration. So as with all LUTs, whether it's due to obstruction, in this case due to detrusor underactivity, you don't need to tell the patient that no operation equals deterioration. So this is a significant amount of data. In women, the situation is different. So as I've said, in our urodynamic unit, 50% of men coming have outlet obstruction, most of it due to the prostate. Only 4% of women have obstruction. So that's much less common. So if a woman presents with low flow and a residual urine, and you're a betting man, you're going to bet that's due to detrusor underactivity, and you're going to be right the vast majority of times. And they present generally with poor bladder emptying, so they may complain of slow stream and difficulty, but often they come with urinary tract infections, because once they get an infection, which obviously these are older women, postmenopausally, if they get infections, then if they've got a residual urine, they're difficult to clear up. They may also be coming with coexisting detrusor overactivity. So some of them also have urgency incontinence. So as I've said, they can have detrusor overactivity during filling and detrusor underactivity during voiding, which sounds a bit confusing, but this has been well described now for the last 30 years. The problem with women, as I've said, is there's no way of defining detrusor underactivity. We have no nomograms. So if we take this lady, is her void normal? So she's straining a bit here for some reason or other at the beginning. It's a good quality trace, and then she voids. She's got a perfectly reasonable flow here of 20. What about her voiding study? How many people here would say this was a normal void? How many would say this pressure's too low and she's got an underactive detrusor? She's not straining, as you can see. How many think this is a normal void? How many think that she might have detrusor underactivity? Okay, so I agree with you. I think this is a normal void. Because, of course, women have much lower urethral resistance, and to achieve the same flow rate as men, their bladder doesn't have to work nearly as hard. So they always have lower voiding pressures. What about this lady? She's 72. She's got a fair bit in her bladder. That's about 400 mLs in her bladder. She's not straining, and here's her flow rate. So she's got a maximum flow rate at that point of 10. And here you can see her detrusor pressure. Again, that would be very low for a man. How many of you think this is a normal void? How many of you think she's obstructed? How many think you think it's detrusor underactivity? Okay, detrusor underactivity has your vote, and you're quite right. We would judge this. We have no means of setting the limits, though. But we would say, from experience, I can't say how good our experience is and how valuable our opinion is in this case, but we would say this low fluctuating flow, which goes on, is due to detrusor underactivity. So how do we manage most patients who come up with low flow and perhaps infections. So this is a woman who's getting on for 70, 5-year history of slow stream. The stream is interrupted and fluctuating, and she gets uncomfortable in the evenings, and that discomfort is relieved by voiding. And she feels like she's got urinary infections, feels as if she's got cystitis, but there's only ever been one positive culture. So we would always do a flow study, and you can see that the flow is not too bad. That's 0 to 25, so that's 10, that's 15, that's about 18, 17 or 18. And she has a post-void residual of 175. It's a fluctuating flow, and if you were just shown this, you'd say, well, that's not a bad flow. So this is so suggestive of detrusor underactivity. So what do we do? Well, I can't speak for the others, but what I do with these patients is I do an outpatient local anesthetic urethral dilatation, just using Hagar's dilators. So I give some local lignocaine, leave the patient for 5 minutes, and then I start at about 10 French, and I go as far as the patient will let me, without torturing them. And you can usually get up to 20 French. And almost invariably, they go in very easily. So I have, in a crude way, I have excluded obstruction. And I'm not worrying about obstruction in these patients. Her flow rate doesn't look like she's obstructed. She wasn't like the flow of the lady I showed earlier. And I'm suspecting detrusor underactivity. So we taught her to double void. We said, well, if your symptoms persist and they annoy you, then we can teach you intermittent self-catheterization. Would I consider urodynamics? Yes, I'd consider urodynamics if she was dissatisfied and wanted us to take things further, although I'm not sure what I would do, whatever I showed on the urodynamics. And really, one doesn't normally do urodynamics unless you have a plan which is affected by the result of the urodynamics. And I couldn't really think of any way in which that would be the case in her. So how do we manage underactive bladder and detrusor underactivity? Well, the answer is extremely badly. What options do we have? Well, we can just sit and do nothing, which is fine. If the patient's happy, I'm happy. We can suggest they double void and just take more time to void. If they find that straining helps them empty their bladder, by all means strain. What about drugs? I'll come back to that. Of course, if they really empty poorly and say they're coming with recurrent urinary infections, then in general we will teach them to do intermittent self-catheterization. Remembering that then you've got to mimic voiding, natural voiding, and so you're likely to get them to do intermittent catheterization 4 times a day. Surgery, reduction cystoplasty and sacral nerve stimulation have not been proven to work in detrusor underactivity, so we don't have any operations. There are a number of operations described, but they're all in very small series of patients. This is the only one which is of any size, and this is about TURP, showing that it doesn't work in terms of detrusor underactivity. Sacral neuromodulation, again, small numbers. Here we've got intravesical electrical stimulation, small numbers. So there isn't much evidence for anything else working. I'm aware that Bethanechol is widely used in India. It's not used at all in Britain. Now, the problem is the evidence. Most of the evidence is very old. It's poor quality evidence. They're not randomized controlled trials for the most part. There are a couple of small randomized control trials. This is in a group of patients having pelvic or anorectal surgery, and it suggests a positive effect from the use of Bethanechol. Then there's a group of women having radical hysterectomy, and in this uncontrolled trial, it is said to allow the patients to remove the catheter earlier after a relatively high dose of Bethanechol. Then there's a group post-hemorrhoidectomy, in which it's said to reduce the need for catheterization. So there is a little bit of other evidence showing that it might work better in detrusor underactivity secondary to neurogenic causes. But overall, the evidence base is weak. Nevertheless, I know that a lot of Indian neurologists use it and find it very useful. And there is actually a new paper, relatively new paper, from 2018, less than a year ago, from a database in the US. And they looked at 17 million patient visits. So that's a big study. 17 million. And they found, surprisingly, that 1% had a prescription for Bethanechol, which I was very surprised at. And the average age was they were postmenopausal women of around 62. And the diagnoses that they had in their charts were atony of the bladder, urinary retention, neurogenic bladder, urinary incontinence, and incomplete bladder emptying. So they look like the sort of patients we would think about giving Bethanechol to. And the visits were primarily for the chronic conditions, and it was typically prescribed continuously. So that implies that it worked, because usually if the drug doesn't work, the patient stops it, because what's the point of taking it? Most often it was being prescribed by urologists, followed by internal medicine clinicians. So Indian urologists are not on their own. To my surprise, a lot of American urologists are using Bethanechol. So it would be good to have some good quality evidence for the rest of us to justify using it. As I've said, you can have detrusor underactivity coexisting with lower urinary tract dysfunction, particularly in the elderly. It's seen in neurological patients as well. And as I've said, you can have overactive bladder due to detrusor overactivity during filling, and underactive bladder due to detrusor underactivity during voiding. And this is much more frequent in older women. In older men, you can see a degree of obstruction and a degree of underactivity. But of course, you can't have significant underactivity and bad obstruction, because if you did, you wouldn't be able to pass urine. It would be as simple as that. So here's a man who's got both. You can see this is the filling phase and this is the voiding phase. So you can see that he has an involuntary detrusor contraction, and he had urgency at that time. It's a decent contraction. But when he comes to void, he has an interrupted, fluctuating flow with very little change in detrusor pressure. So he has detrusor overactivity during filling and detrusor underactivity during voiding. Now, I'd just like to tell you about my friend Dave. Now, we play tennis together. Dave and I play, and I hadn't seen him for a long time, and I said, "How are you, Dave?" And he said, "You can help me." And I thought, that's a funny thing to say. He didn't say, "How are you? Nice to see you again." He said, "You can help me." So the story was that he'd been referred to our institute a few months, well, I saw him in about February this year. So about 9 months previously, I hadn't seen him in the meantime. He had gone with a 5-year history of difficulty voiding, slow stream hesitancy, and he'd got into the habit of doing the Cradé maneuver, pressing on the lower abdomen to try and push the urine out, which is pretty unusual for a man, I think. And he then, in the end, was having to sit to strain to void. And the reason for that, of course, was if you push very hard, you might have your bowels open. So you don't want to be standing up. So he sat on the toilet in case his bowels opened. He didn't have, when this all started, he had no frequency, he slept through the night. Latterly, though, he was getting up once, sometimes twice. A GP gave tamsulosin, which seemed to help for a bit, but hadn't been any use for the last 12 months. And he was worried he might get kidney damage. He's an intelligent guy. He thought he might get kidney damage, particularly when somebody told him that he was leaving 300 ml in his bladder. He's had a bit of depression and takes some antidepressants, and he had a bit of cardiac problems. So, it turns out that he had been investigated, although our department didn't seem to know this. He'd had some chest problems, and he'd had a CT in 2017 which showed a very distended bladder but said no hydronephrosis. And nobody did anything about this. And this was the GP. That wasn't us. We didn't see him for another year. He had then had an ultrasound in the community which showed that he had a bladder volume of 1,027. He voided about 400, leaving a residual of 600, and was said to have a normal-sized prostate. For some reason, they did a flexible cystoscopy and then said he had an enlarged prostate. So this was the same group of people, so they were a little bit inconsistent. He was then seen by us, and the young doctor, it was a trainee doctor, said, "You've got this big residual. I'm not happy for you to go home without a catheter." Okay, so the person arranged for him to have a catheter in. He tells me he wasn't given a choice, really, because although the person said, "It's your decision," they then immediately said, "But I strongly recommend that you don't go home without a catheter." So he took the doctor's advice. 4 weeks later, he went on holiday to Greece, and on the flight back became really sick, very unwell, and by the time he landed in London, he had a high temperature. He was taken to a hospital close to the airport. Those of you know hospital, it was Ealing Hospital, which is quite close to the airport, and he was diagnosed as urosepsis. He was on IV antibiotics. The antibiotics didn't work. He got fluid overloaded. He then got diarrhea. So he had a real bad time and was in for a week. He then came back to Bristol, and then he was seen again in the autumn and switched to intermittent catheterization. So was this good management by the young doctor that saw him in June? No, it wasn't good management. What would have been good management would have been to have known the result of the CT, which they didn't seem to know about, and then get a follow-up ultrasound to make sure that the upper tracts were okay. Now remember, my friend Dave at this point didn't really have any symptoms. He wasn't bothered. He was now getting up once a night, but he was having this difficulty avoiding. He had to sit down and really had to strain. So if I'd seen him back then, I would have done an ultrasound in the clinic. If the upper tracts were okay, which they were, I would have then discussed with him intermittent catheterization. And I would have left it to him whether he did it or not. Now, if he said, "I don't want to do it, my symptoms don't bother me," I would have allowed him to carry on and then see him on a regular basis. So we have to be careful about what advice we give. There's a very good longitudinal study about big residual urines carried out in a hospital close to Bristol, and they followed men with residual urines of more than 300 mLs for 5 years. And basically, nothing happened to these men. They didn't get a lot worse. 2 or 3, I think there were 60 men, 2 or 3 had to come in and have a TURP. So he's now needing to do intermittent catheterization 5 times a day. He gets 500 to 700 mLs first thing in the morning. He now can't pass any urine. So obviously before he was allowing his bladder to distend to 1,000 mLs, by which time he then of course had some tension in the bladder wall, so he could void, but left this big residual urine. He'd had no further infections, and he was booked for urodynamics. I asked him, "Well, would you have a TURP now?" And he said, "No, because I have a friend who didn't do very well from a TURP, and I've got used to doing intermittent catheterization. I'm quite happy." And that's a regular study. And he said to me, "I don't understand why they didn't offer intermittent catheterization when I went in June," which was a good thing to say. So he was booked for urodynamics. I didn't interfere in that because I was interested to see what it would show. So here's the filling phase. You see it's a good quality urodynamics, and he's filled here up to about 400 mLs, and now the filling has stopped and he's trying to void, and there's basically no detrusor contraction and he couldn't pass any urine. So I'm sure his diagnosis is detrusor underactivity. So it just shows how careful we've got to be with our patients. We did a blood pressure profile, and indeed he has got he has got an enlarged prostate, so that's his prostate. But as I said, that's not a fantastic correlation with actual obstruction. So in conclusion, underactive bladder is a symptom diagnosis. Detrusor overactivity is a urodynamic diagnosis. In men, we can define it because we have a nomogram. In women, you just have to use clinical judgment. A new approach may help, and we're looking in detail at flow patterns to see whether there's something in the flow pattern rather than the numbers which will make a difference. We still have limited options. There is a drug trial which is just starting, looking at a drug for detrusor underactivity. So I think we need to identify detrusor underactivity, particularly in men, to prevent them from having unnecessary TURPs. So thank you very much for listening. I'm very fond of the seaside, as you gathered from our visit to the seaside next to Manipal, and we go down here, and I'll show you why I show you this, but what's the name of the urologist who has 3 children who have played Test cricket? Come on, Professor Chor is an expert in cricket. Who is it? Well, what country does the person come from? Holland, very good, because the Dutch always wear orange. So he has 2 sons who have played Test cricket, and here you can see them in South Africa at the ICC Cricket World Cup. So they played Test cricket for Holland, and his daughter has played Test cricket for Holland women's team. Well, I'm very disappointed that you don't know his name. And he's a very, very nice man, so if you ever meet him, have a chat to him. And he's called Rien Nyman. He's a very well-known pediatric urologist. He's just retired. And this is my own star cricketer. This is my eldest son. And you see, he bears a resemblance to Chris Gale or Russell. You know, he's about 6'3". He weighs about 100 kilos, and he can hit sixes off the back foot. His style, is not quite Tendulkar yet. And here we're playing beach cricket. So I play cricket once a year on the beach at the seaside where we go to, which is great fun. So I think that's the ball there. So I think he did hit the ball, which is encouraging. And this is great fun because we also go in a rowing race, and we row basically from here right round the corner of that. So we keep our fitness in the summer as well. Cricket and rowing, I can recommend it. Thank you very much indeed.
If I could just ask you about this, what you mentioned about both the patients. You showed 2 patients to us, and you said that in a lady, if she wants to strain and empty, I wouldn't mind. That was the statement you said about a lady who was having about 300 ml residual. Would you remember that, what you showed just now? If a patient continues to strain, is that likely that they will actually develop stress urinary incontinence later? Which was in a way mentioned about the gentleman which you said, that he was straining or he was doing Crady's maneuver, and he had to sit down because he would empty his bowels. He may empty the bowels. So in a way, aren't you really damaging the pelvic floor? And so you shouldn't encourage them to do either of them, and they should go on intermittent self-catheter.
Well, I think that's a very good question. But we should be aware, we men should be aware that most women strain to pass urine. Why do they strain to pass urine? Because they're so busy looking after us, they don't have time to hang around in the toilet. And because women have low urethral resistance, straining in a woman makes a big difference to the speed at which they pass urine. Whereas for us, when we haven't got a big prostate, it doesn't make such a big difference. So lots of women do strain. However, you're quite right in questioning it, because I remember very well a woman, and I can't remember what her neurological problem was. She was mobile, she used to ride a horse, but she had difficulty with sphincter relaxation, and she had to strain. Her bladder didn't work and she had to strain. And she did develop prolapse, and she was a young, thin woman. She'd already developed prolapse. And I said, I want you to learn intermittent catheterization, because I think you're having to strain so much that your prolapse will get worse and worse and you'll need surgery. So there are circumstances, I think, where you're quite right to question that. But I'm not asking them to go blue in the face. This young woman was literally going blue in the face. She was straining. She had to strain so hard because her sphincter would not relax. So it's something you should think about.
How would you teach your female patients to do self-catheterization? Especially they found it difficult to do self-catheterization.
Not really.
Sorry?
How do you teach CIC?
How do I teach it? I don't teach it. I get the nurses to teach it. So we're very lucky because we have excellent nurses, both in the community and in our urological institute. So it's pretty straightforward. I think they have no problem teaching the vast majority of people.
Usually they find it difficult to see their own CIS.
You use, for example, the tricks that you use is to use a mirror. So you teach the woman to use a mirror, so she puts a mirror and then she can see the meatus, and they use a mirror usually only for a short time, and then they get very good at catheterizing themselves, as the same as men do.
What is your rationale for urethral dilatation in these patients? If you are doing calibration just to rule out any obstruction, that's okay. But why do you dilate from 14 to 20? How does it benefit to the patient?
Well, there's no science in it. There's no science. Remembering that actually you have to have, if your urethra is 8 French or more, you have a normal flow rate. So actually even putting just a 10 Bucci in, if it falls in, then the patient has no obstruction. So it's a very simple thing to do, and I obviously don't hurt the patient. As soon as the patient says, oh, that's a bit uncomfortable, I stop. And if I'm stopping at a small caliber, then of course that might be significant, and then I would take it further. But in the vast majority of patients, it's not a problem, and you don't find anything. And then when they come back later, you say, did that make any difference? And they say, no, it made no difference, as you would expect, because there was never an actual obstruction. The problem was detrusor underactivity.
Sir, yesterday you told that you do not do aerodynamics in catheterized patient. Yesterday in the class you told me. But in our institute we get many patients who have got out from outside, come from outside with referral with failed trial without catheterization. He's got a catheter in situ. We are told we are referred for aerodynamics, and in them many times we found that they cannot void during the voiding phase. They have got catheter in situ for many months, like 6 months, 10 months. They have failed trial without catheterization, and on alpha blocker they failed to void, and even on aerodynamics they failed to void. So what is your take in this situation?
So he's saying he does urodynamics in patients with a catheter, who've had a catheter.
If they are on the catheter, most of the time they don't void and
No, well, I agree with you. No, I think that's correct. If they've come in with a catheter in, if they've had acute retention, they come in, and then at some point you do urodynamics. I agree with you, most of them don't void. In fact, we don't do urodynamics because we found it wasn't much use. So we just go ahead and do a TURP in these patients. Now, if it's an acute retention, I think, but I don't know, I think that usually happens in men who have a good functioning detrusor. I think if you have detrusor underactivity as the main problem, then you have chronic retention before you go into retention. So I think acute retention patients, if you take a history from an acute retention patient, then usually we've never seen the patient. They've never come up with LUTs. They're a completely new patient. And they go along and then they'll say, well, about 6 months ago my flow started to deteriorate. And really, I wasn't surprised that I went into retention. And in those patients with a good history, I think they do well from TURP. But we always do trials without catheter, but we don't do urodynamics. And I was asking one of my senior colleagues what he thought about it, and he agreed with me that this policy seems to work. We don't have lots of patients coming back not being able to void and requiring a catheter. Now there is a choice here, and the choice is that you could teach patients intermittent catheterization rather than put in an indwelling catheter. And there was an interesting study some years ago from Sheffield. At one time in the UK system, you would have to wait a year maybe for a TURP, even if you had a catheter. So the urologist realized, well, that's not very nice. So why don't we offer everybody the choice of an indwelling catheter or intermittent catheterization? So they offered all these patients intermittent catheterization, and lots of them took that offer. And then they called for them to come in. And when they came in, 30% of the men said, I don't want the operation. I'm perfectly happy. I can manage very well. It's an easy part of my life. Like my friend Dave, he says it's no problem. He goes on holiday. I phoned him up the other day, and he was on holiday in the middle of Portugal. He took his catheters with him. He was not, his social life is not disrupted. So I think there are a number of alternatives that we have. The other thing is, of course, if you teach them intermittent catheterization, some of them will start voiding again. And then if they start voiding again, of course, you can then do urodynamics, and you will get some useful results as to whether it's obstruction or whether it's detrusor underactivity.
That's my question, sir. Most of this.
What he's asking is that
You mean
they
I've
found
answered
catheter for a long time, like for 6 months,
Yeah.
and they are not able to do it.
No, I think that's the problem, isn't it?
How can I rule out, sir, accontacted detrusor in these cases?
You've had the catheter in for 5 or 6 months.
Yes, sir.
They probably had some urinary infections. Their bladder wall will be inflamed. And so you're trying to investigate a situation which is very abnormal by that stage. And I think that's one reason why I've never trusted the urodynamics. If the patient's bladder detrusor doesn't contract, I don't know whether it's because it can't contract or whether it's because the circumstances, inflammation, infection, are preventing contraction.
Now, my question is, how can I rule out accontacted detrusor in these cases?
You can't rule it out. I would switch the patient. If the patient's fit, I would offer them intermittent catheterization instead of an indwelling catheter. If the patient's not fit, we would switch them from a urethral catheter to a suprapubic catheter, because that's more comfortable and a reduction in urinary infections.
I think this is not an uncommon scenario, at least in our center, and we do urodynamics sometimes. So I can tell you what we find typically. So most often it's not a problem of them not being able to void in the test. Usually it's a problem of them showing storage abnormalities, or sometimes you're not able to fill the bladder. So the original ultrasound scan on the basis of which the catheterization might have happened might have shown, for instance, that they had a liter of urine inside the bladder. But now when you try and fill the bladder and you find you're not able to fill 200 ml because you start getting phasic contractions, the compliance apparently is low. So it's more a problem of getting the bladder, filling up the bladder, rather than getting a problem with being able to interpret a voiding phase. In a vast majority, it is possible to get voiding phase information. And I would discount the storage phase abnormalities in such patients and do multiple cycles, not one cycle. So do multiple cycles, and often you find that the compliance improves, the phasic contractions settle as you do your second or your third cycle of filling. So in a vast majority, you do get an answer if you do a pressure flow study in these patients despite the long period of catheterization.
You just end up doing TURPs on all of
No, so you have a better method of counseling, because you can't tell both things in the same breath. You can't tell us that just on the basis of history you're not able to make a good decision, and then in this situation say that you won't do a urodynamics, because when you do a urodynamics, in a vast majority you get a decent answer. So if the patient doesn't generate a contraction at all, it's a different issue.
What proportion of these retention men do you end up doing a TURP?
On a substantial but not all. So because if they don't, if they don't, now I understand I should. So if they don't generate a contraction, at least we will counsel them better. And at that stage, they may take a decision, okay, I won't go through a TURP because it makes sense.
Sir, for detrusor underactivity, especially in female, any role of alpha blockers?
That's a very interesting question. In England, alpha blockers in females don't work. Now, I'm not being funny about this, but that seems to be true. We always try it, and it never seems to make any difference. But there are good quality papers from India, from Southeast Asia, and from Korea, which show that alpha blockers work in female voiding dysfunction.
Sir, it's
So I don't understand the difference, but there seems to be a difference.
Are you allowed to prescribe alpha blocker in females?
Sir, for detrusor underactivity, it says that bithinecol or none of the treatment is useful. But if we give alpha blockers, the bladder neck resistance decrease and they void. Like such kind of things, sometimes we heard, sir. So that's why.
I don't have any problem with you using them.
But
I'm just disappointed that they don't work in our women who have voiding dysfunction.
Thank you, sir.
We actually looked at it, it doesn't work. The issue about
I think I'm slightly intrigued about this acute retention and catheterization, because we never do urodynamics in a patient with acute retention. Only when you have a diagnosis in doubt, that you are not sure about the retention, or there is a history of chronic retention, and you are worried about whether the very small number of patients who come and present like acute and chronic retention. There also, with the catheterization, what are we going to do here? Because our problem is, the urodynamics in that situation has never been able to answer our question. Ultimately, it boils down to your clinical decision. If the patient has no neurological factor, no signs of neuropathy, he had a history suggestive that his flow rate was decreasing for over a period of long time, and then he had, mostly we know that I know this is difficult, but my problem is, we have done this thing, and I completely don't agree with, because we never found answers in patients with retentions. So usually our practice is not to offer. We tell the patient that in a situation like this, everything points towards obstruction. If you want, we can offer you TURP. Prognosis is guarded. If you don't want, stay on intermittent catheterization or change to suprapubic. Many times patients don't void in a urodynamic lab. That does not mean he's got acontracted detrusor. So I personally think urodynamics cannot and does not provide answers to all the situation. We want it to be, but actually it does not. So
Thanks.
it's not like a test
Thanks,
which
Nitin.
I get answer every time.
We're way behind schedule. We will. Thanks, Nitin. Thanks. We'll move on to the next talk. He wants us to stop.
The next talk is by Dr. Rajiv TP.
Dr. Rajiv TP on managing the neurourological patient. What do the guidelines say? Dr. Rajiv.
Rajiv TP, all of you know that he is the current secretary of USI. He is the professor and so he is a professor and head of department at Guwahati Medical College, and he is going to tell us about what is the guidelines of neurological patients.
Good afternoon, everyone. Respected chairpersons, and first of all, thanks to the BOE for giving me the opportunity to speak on this topic here. So all of you know, neurourology concerns the nervous system control of the genitourinary tract and conditions causing abnormal urination. There are three societies which have been in for making the guidelines. One is the International Continence Society, European Association of Urology, and International Neurourology Society. But as of date, we have a well-balanced guidelines from European Association of Urology only. Functions of the lower urinary tract are basically storage and voiding of urine, and part of the nervous system that regulates lower urinary tract function is disseminated from the peripheral nerves in the pelvis to highly specialized cortical areas. The extent and location of the neurological disturbance determines the type of neurourological lower urinary tract dysfunction, which may be symptomatic or asymptomatic. But the most common long-term sequel of neurourological lower urinary tract dysfunction is upper tract damage. And it is essential to identify patients with lower urinary tract dysfunction regarding the symptoms, and as because the symptoms and long-term complications do not correlate. Treatment and intensity of the follow-up examinations are based basically on the type of neurourological lower urinary tract dysfunction and the underlying cause. So nervous control of the lower urinary tract, basically brain, which deals with sensations and decisions. Brainstem coordinates the storage and voiding, whereas the spinal cord guards various reflexes like guarding reflex, ejaculation, which is under the sympathetic nervous system motor nucleus. Bladder contraction is under the control of parasympathetic nervous system nucleus. Outlet contraction and relaxation by the on-off nucleus, and sacral cord mediates voiding in infants. So there are various levels of lesion. If it is a suprapontine lesions, patient may be unaware of filling and flow, may not be able to initiate voiding and may result in enuresis. If it is a pontine level lesion, there can be detrusor sphincter dyssynergia or detrusor overactivity. If it is a subpontine or suprasacral lesion, there will be detrusor overactivity, DST or hyperreflexia. If it is a subsacral lesion, there can be detrusor reflexia, stress urinary incontinence and poor compliance. And if it is a peripheral lesion, there can be reflexia or stress urinary incontinence. These are the various classification of the level of the lesion, that is suprapontine and pontine lesions and diseases. These are the various conditions. Lesions between caudal brainstem and sacral spinal cord, that is a spinal cord injury, which is the most common, followed by spina bifida. Lesions of peripheral nervous system, various lumbar spine degenerative disorders, peripheral neuropathy, and after all, lastly, the disseminated central disease, that is multiple sclerosis and Parkinson's disease. There are various classification systems have been proposed, but the basic simple classification focusing on the therapeutic sequences have been developed by the Medes-Becker, and this has been followed by the European Association of Urology. This classification describes several neurological lower urinary tract dysfunction symptoms based on the contraction state of the bladder and external sphincter, urethral sphincter during voiding and the filling phase. So these are the various classification based on the Medes-Becker classification system. The bladder, in one condition bladder may be overactive, as well as the external sphincter may be overactive. Other situation may be bladder is overactive, but the external sphincter may be underactive. Another situation is bladder is overactive, but the external urethral sphincter is normoactive. And another situation is underactive bladder and overactive sphincter. Sometimes it may be underactive, both the bladder and the sphincter are underactive. Another condition may be detrusor is underactive, whereas the sphincter is normoactive. And another may be normoactive bladder, overactive sphincter. And another may be normoactive bladder and underactive sphincter. So suprapontine lesions, basically we have to concentrate on the history, predominantly the storage symptoms. Ultrasound may show insignificant post-void residual urine, and urodynamic study may reveal detrusor overactivity. So this is a situation where there is an overactive bladder and a normoactive external urethral sphincter. Spinal lesions, that is infrapontine to suprasacral level lesions, history may show both storage and voiding symptoms. Ultrasound will show raised post-void residual urine. Urodynamic study may reveal detrusor overactivity as well as detrusor sphincter dyssynergia. So this is a situation where the bladder is overactive as well as the sphincter is overactive. Sacral and infrasacral lesions, history will predominantly show voiding symptoms. Ultrasound again may show raised post-void residual urine. Urodynamic study may reveal hypocontractile or a contractile bladder. So this may be because of an underactive bladder with a normoactive sphincter, or it may be an underactive bladder along with an underactive external urethral sphincter. Timing of diagnosis and treatment are very important. Early diagnosis and treatment are essential in both congenital as well as acquired neurological lower urinary tract dysfunction. Irreversible changes can occur within the lower urinary tract even with a normal neurological reflexes. This is a level of evidence 3. In lower urinary tract dysfunction can be the presenting feature of a neurological pathology with a level of evidence 3. Early intervention in the form of intermittent catheterization can prevent irreversible deterioration of the lower as well as the upper urinary tract, level of evidence 3. So when you take a history, the present history is important, whether there is any history of present medication, lifestyle of the patient, like intake of smoking, intake of alcohol and various drugs, what is the quality of life and what are the life expectancy. Specific urinary history concentrates on the onset of the urological history, relief after voiding in order to detect the extent of a neurological lesion in the absence of an obstructive uropathy, what is the bladder sensation, initiation of micturition, presence of enuresis, mode and type of voiding. Then in the neurological history, we have to see whether it is an acquired or a congenital neurological condition, mental status of the patient, neurological symptoms with onset, evolution and any treatment advocated, and the presence of spasticity or autonomic dysreflexia. Next is regarding the bowel history. Then the sexual history is important, that is genital or sexual dysfunction symptoms, sensation in the genital area. Specific to the male, it is erection and ejaculation, and specific to the female, it is dyspareunia and lack of orgasm. Past history is also important as well, and this is a sort of bladder diary. So bladder diaries provide data on the number of voids, voided volume, pad weight, and episodes of incontinence and urgency. Although a 24-hour bladder diary recording should be done for 3 consecutive days, it is reliable in women with urinary incontinence, but no research has been done on bladder diaries in a neurourological patient. But nevertheless, to say bladder diaries are considered a valuable diagnostic aid. A voiding diary is also useful in patients performing intermittent catheterization. This is a level of evidence 4. Quality of life questionnaires, assessment of the patient's present and expected future quality of life is very much important in order to evaluate the effect of therapy advocated. Several objective and subjective tools have been used to assess the influence of neurogenic bladder on quality of life, especially in patients with spinal cord injury. Quality of life index in spinal cord injury patient and Colivin are the 2 validated questionnaires with consistent sensitivity in patients with a neurogenic bladder. Neurogenic bladder symptom score has been validated in neurological patients in order to measure the urinary symptoms and their consequences. On physical examination, one should do a global neurological status assessment is very much mandatory. Focused neurological assessment is of great significance in neurourological patients. These are the various dermatomes you have to assess and the various reflexes you have to elicit in these patients. So focused neurological assessment, sensation S2 to S5 level, whether the presence of the sensation, whether increased, normal, reduced or absent, and type, whether it is sharp or blunt, and afflicted segments has to be recorded. Then various reflexes, bulbocavernous reflex, perianal reflex, knee angle reflexes and plantar reflexes to be evaluated. Anal sphincter tone, whether they are present or absent, and if present, what is the status. Voluntary contractions of the anal sphincter and pelvic muscles also has to be evaluated, and prostate palpation. One caution has to be there, that is the autonomic dysreflexia. Yesterday it has been discussed in detail, especially in upper cord injuries. Autonomic dysreflexia is a sudden and exaggerated autonomic response to a stimuli in patients with spinal cord injury or dysfunction above the level of T5, T6. Malignant hypertension is a relatively common manifestation in these patients and can have life-threatening results if not properly managed. This has got a level of evidence 3 and grade C. So what are the EUA recommendations on history taking? Take an extensive general history and concentrating on past and present symptoms. They say the strength of rating is very strong. Taking a specific history for each of the 4 mentioned functions like urinary, bowel, sexual and neurological symptoms, it's very strong rating. Paying special attention to the possible existence of alarm signs like pain, infection and hematuria fever that warrant further evaluation, it's a strong rating. Use of available validated tools including the Colin and quality of life for urinary symptoms and quality of life for bowel dysfunction in multiple sclerosis and spinal cord injury patients. In addition to the generic questionnaires can be used. It has a strong rating. And use of MSISQ 15 and MSISQ 19 to evaluate sexual function in multiple sclerosis patients, strong rating. Then regarding the physical examination, acknowledging individual patient disabilities when planning further investigation, it has a strong recommendation. Describe the neurological status as completely as possible, including the sensations and reflexes in the urogenital area. It has a strong recommendation. Testing the anal sphincter and pelvic floor function, again strong recommendation. Perform urinary analysis, blood chemistry, bladder diary, residual and free flowmetry, incontinence quantification and urinary tract imaging as a strong recommendation. This is as per the EAU guidelines 2019. Now coming to urodynamics, it's the only method for an objective assessment of the function of the lower urinary tract. Invasive urodynamic is a mandatory assessment in case of neurourological patients. Any technical source of artifacts must be critically considered, and repeating the urodynamic evaluation is very much crucial in clinical decision making, since repeat measurements may yield completely different results. In those patients who are at risk of autonomic dysreflexia, it is advisable to assess the blood pressure during the urodynamic study. Rectal ampulla should be empty before the start of the investigation, and all urodynamic findings must be recorded in detail in accordance with the International Continence Society technical recommendation. So these are already highlighted by my earlier speakers. What are the evaluation done in urodynamic, like free uroflowmetry and assessment of the post-void residual urine, filling cystometry, detrusor leak point pressure, pressure flow study, electromyography, urethral pressure measurement, video urodynamics, ambulatory urodynamics, and triggered tests during urodynamics. What are the triggered tests? You trigger by coughing, triggered voiding or anal stretch, fast filling cystometry with the use of cool saline is known as the ice water test area. This can discriminate between an upper and a lower motor neuron lesion. Patients with upper motor neuron lesions develop a detrusor contraction if the detrusor is intact, whereas patients with lower motor neuron lesions do not. But however, the test does not seem to be a fully discriminative in other types of patients. Bethanacol test, as already highlighted, has no indications at the present situation. Now, special neurophysiological test, that is EMG, in a neurophysiological settings of pelvic floor muscles, urethral sphincter or anal sphincter, nerve conduction studies of the pudendal nerve, reflex latency measurements, that is bulbocavernous and anal reflex arcs, evoked response from the clitoris or glans penis, sensory testing on bladder and urethra. So classic patients are either a lower motor neuron patient or an upper motor neuron lesion. Lower motor neuron lesion may be categorized into safe type and unsafe type. Safe type are those with peripheral injury, that is outlet failure, straining and reduced bladder sensation. Unsafe variety are those having sacral injury, where there will be outlet failure, reduced compliance, straining and reduced bladder sensation. Upper motor neuron lesions will have detrusor overactivity associated with incontinence, detrusor spindle dyssynergia if there is a spinal cord or brainstem injury, enuresis if it is cerebral, increased PVR and lack of bladder sensation. So what does EUA say about the urodynamic? Perform a urodynamic investigation to detect and specify lower urinary tract. This has a strong recommendation. Non-invasive testing is mandatory before invasive urodynamic is planned. That is as a strong recommendation. Use of video urodynamics for invasive urodynamics in neurourological patients. If this is not available, then one should perform a filling cystometry continuing into a pressure flow study. This is a strong recommendation. Use of a physiological filling rate and body warm saline as a strong recommendation. What about the renal function in these patients? In those with neurourological disorders, upper urinary tract is always at risk, especially in those patients with high detrusor pressure during the filling phase. Although the effective management can reduce this risk, there is still a high incidence of renal morbidity. Especially in patients with spinal cord injury, there is a high risk of renal failure than in those with slowly progressive traumatic neurourological disorders like multiple sclerosis and Parkinson's disease. In patients with poor muscle mass, cystatin C-based glomerular filtration rate GFR is the most accurate assessment in detecting chronic kidney disease than serum creatinine-based estimated GFR. No high-level evidence publications are available to show the optimal management in order to preserve renal function in these patients. Primary aim of the treatment of a neurourological patients with symptoms, the priority should be to protect the upper urinary tract. One should achieve or maintain the urinary continence. One should try to restore the lower urinary tract function and improve the patient's quality of life. Renal failure is the main mortality factor in those with spinal cord injury who survive trauma. Keeping the detrusor pressure during both filling and voiding phases in a safe limit should be the top priority in the treatment of patients with neurourological lower urinary tract dysfunction. In those patients with a high detrusor pressure during the filling phase, that is detrusor lower activity coupled with lower bladder compliance, treatment is primarily aimed at conversion of an overactive high pressure bladder into a low pressure reservoir despite the chances of increasing residual urine. So reducing the detrusor pressure contributes to urinary continence and consequently to a good social rehabilitation and better quality of life. It's also pivotal in preventing the chances of urinary tract infections. Complete continence, however, cannot always be achieved in these patients. What are the non-invasive conservative treatment? One is assisted bladder emptying. Secondly, it can be triggered reflex voiding, that is stimulation of the sacral or lumbar dermatomes in patients with upper motor neuron lesion. This can elicit a reflex detrusor contraction. All assisted bladder emptying techniques require low outlet resistance. Even then, high detrusor pressures may be still present. Hence, patients need dedicated education and a close urodynamic and urological surveillance. Application of external appliances. Social continence is achieved by collecting urine during continence. This is by the use of pads or condom catheters. Sometimes earlier spinal clamps were applied, but nowadays it is absolutely contraindicated in those patients with detrusor overactivity or low bladder compliance. Now coming to neurourological rehabilitation. Bladder rehabilitation including electrical stimulation. So a strong contraction of the urethral sphincter or the pelvic floor will stimulate the efferent fibers, and an anal dilatation, manipulation of the genital region and physical activity can stimulate the efferent fibers, and this will induce inhibition of micturition in a reflex manner. Electrical stimulation of the pudendal nerve strongly inhibit the micturition reflex and detrusor contraction, and this can support restoration of the balance between excitatory and inhibitory inputs at the spinal or the supraspinal level. Another method is peripheral temporary electrostimulation, that is the tibial nerve stimulation and transcutaneous electrical nerve stimulation. And the peripheral nerve temporary electrostimulation combined with pelvic floor muscles training and biofeedback are tried mostly in multiple sclerosis patients, and combination of this is found to be more effective than when they are used as either therapy alone. Now another method is intravesical electrostimulation, basically tried in patients with incomplete spinal cord injury or myelomeningocele. Repetitive transcranial magnetic stimulation are tried for improvement of neurourological symptoms, but these are still under experimental stage. Now coming to drug treatment, commonly a combination of therapies are used. Example for use of intermittent catheterization coupled with antimuscarinic drugs. These are basically advised to prevent upper tract urinary tract damage and improve the long-term complications, especially in those patients suffering from spinal cord injury and multiple sclerosis. So what are the antimuscarinic drugs used? First-line choice for treatment. It's a first-line choice for treatment of detrusor overactivity. It helps in increasing the bladder capacity, reducing the episodes of urinary incontinence which are secondary to detrusor activity, and basically this is achieved by inhibition of the parasympathetic pathways. Various drugs have been trialed. In the sequence earlier it was oxybutynin, then it was trospium, tolterodine, propivarin. These are the established drugs. And darifenacin and solifenacin were evaluated in detrusor activity secondary to spinal cord injury patients and multiple sclerosis. A pilot study using solifenacin in detrusor activity due to Parkinson's disease showed an improvement in urinary incontinence. And there are newer drugs which has come. That is, one is festoridine. It is an active metabolite of tolterodine, and this has been found to be of great use in treating patients with neurourological disorders. And favorable results have also been reported with the use of imidafenacin in suprapondyne lesions as well as spinal cord injury patients. Now coming to beta-3 agonists, the role of mirabegron is still unclear, even though it has been used extensively. But mirabegron has not shown any significant effect on detrusor pressure or systometric capacity, despite they have shown reported improvements in LUTs in patients with multiple sclerosis and spinal cord injury. Combination therapy with mirabegron and desmopressin in multiple sclerosis patients have been tried, and they have shown promising results. Drugs for avoiding symptoms, detrusor underactivity, cholinergic drugs such as bethanacol and distigmin, decreasing bladder outlet resistance, alpha blockers like tamsulosin, naftopidil, and silodosin, and increasing bladder outlet resistance. Several drugs have shown efficacy in selected cases of mild stress urinary incontinence, but there are no high-level evidence in stress urinary incontinence in neurological patients. So EAU recommendation of drug treatment, use of antimuscarinic therapy as the first-line medical treatment for neurogenic detrusor overactivity as a strong rating. Prescribe alpha blockers to describe bladder outlet resistance, again as a strong rating. Do not prescribe parasympathomimetics for underactive detrusor as a strong rating. Minimally invasive treatment like catheterization, intermittent self or third-party catheterization should be the gold standard for the management of patients with neurological lower urinary tract dysfunction. It is effective in those with detrusor underactivity or a contractile bladder. It is also tried in detrusor overactivity, provided that the overactivity can be controlled. Sterile intermittent catheterization was originally proposed by Gutman and Frankel. It significantly reduces the risk of UTI or bacteriuria in these patients compared with clean intermittent catheterization introduced by Lepides. But it cannot be considered as a routine procedure. Insufficient patient education and inherent risk of UTI in patients with neurourological lower urinary tract dysfunction are the contributing factors. So average frequency of catheterization should be 4 to 6 times per day, and the catheter size should be 12 to 14 French. Less frequent catheterization results in higher catheterization volume and a higher risk of UTI. Lesser risk of UTI. More frequent catheterization increases the risk of cross infections and other complications. Average bladder volume at catheterization should be lower than 400 ml. Indwelling transurethral catheterization and to a lesser extent suprapubic cystostomy are significant and early risk factors for UTI and other complications, so they should be avoided. Silicone catheters are preferred as they are less susceptible to encrustations and no chance of latex allergy in neurological lower urinary tract dysfunction population. So what is the AUA recommendation regarding catheterization? Use of intermittent catheterization whenever possible, aseptic method as a standard treatment for patients who are unable to empty the bladder, as a strong rating. Thoroughly instruct patients in the technique and risks of intermittent catheterization should be explained, the strong rating. Avoid indwelling transurethral and suprapubic catheterization wherever possible. It has got again a strong rating. Intravesical drug treatment, 0.1% oxybutynin hydrochloride and antimuscarinic have been tried in these patients. Vanilloids, capsaicin and resiniferatoxin desensitize the C fibers for a period of few months. So EAU recommendation regarding intravesical therapy, use of botulinum toxin injection in the detrusor to reduce neurogenic detrusor activity in multiple sclerosis or SCI patients if antimuscarinic therapy is ineffective. Again, it has a strong rating. Bladder neck incision is effective in a fibrotic bladder neck. Again, strong recommendation. Intravesical drug treatment offer intravesical oxybutynin to neurogenic detrusor overactivity patients with poor tolerance to oral route. Again, it has got a strong rating. Botulinum toxin is a long-lasting and reversible chemical denervation that lasts for about 9 months, and toxic injections are usually mapped over the detrusor in a dosage that depends on the preparation used. It is provenly effective in patients with the disorders due to multiple sclerosis, spinal cord injury, and Parkinson's disease. Repeated injections possible without loss of efficacy. Current research focus on different delivery approaches to injections like liposome encapsulated botulinum toxin. Bladder neck and urethral procedures. Reduction of bladder outlet resistance may be necessary in order to protect the upper urinary tract. It may be achieved by a chemical denervation technique of the sphincter or by surgical interventions like bladder neck or sphincter incision or urethral stent. Botulinum toxin A injection in sphincter is also tried to treat detrusor sphincter dyssynergia. What are the bladder neck and urethral procedures advocated? It may be in the form of balloon dilatation, bladder neck incision, sphincterotomy, and use of stents. Then bladder neck and urethral procedures. To increase the bladder outlet resistance, bulking agents have been tried, but the disadvantage is a relatively early loss of continence in patients with urological disorders. Urethral inserts have been tried, like urethral plugs or valves, for the management of stress incontinence, have not been applied in urological patients. Results of active pumping urethral processes for treatment of underactive and a contractile detrusor have been tried, but the results have been disappointing. So what is the AUA recommendation? Botulinum toxin injection in the detrusor is the most effective minimally invasive treatment to reduce neurogenic detrusor overactivity. It has a grade A evidence. Sphincterotomy is the standard treatment for detrusor sphincter dyssynergia, grade A evidence. Bladder neck incision is effective in a fibrotic bladder neck. It's a grade B evidence. Bladder neck and increasing the bladder outlet resistance has the inherent risk of high intravesical pressure. Procedures to treat sphincteric incontinence are suitable only if the detrusor activity can be controlled and no significant reflux is present. Simultaneous bladder augmentation and intermittent catheterization may be necessary. Procedures used were urethral sling, artificial urethral urinary sphincter, adjustable continent device, functional sphincter augmentation, bladder neck and urethral reconstruction. Endoscopic techniques have also been tried for anatomic bladder outlet obstruction in the form of TURP, bladder neck incision, urethrotomy, and sphincterotomy. Denervation and de-efferentiation sacral neuromodulation, sacral anterior root stimulation by Brindley, sacral rhizotomy, and sacral neuromodulation are the various methods advocated. When the bladder is covered by striated muscle which can be stimulated electrically or can be contracted voluntarily, voiding function can be improved or restored. Rectus abdominis and the latissimus dorsi muscle are the things tried. Aim of auto augmentation to reduce detrusor overactivity or improve lower bladder compliance. Advantages are low surgical burden and low rate of long-term adverse effects. Replacing or expanding the bladder by intestine or other passive expandable coverage improve bladder compliance, and at least it can reduce the pressure effect of detrusor overactivity. So these are the various types. Continent diversions is the first choice, or it can be an incontinent diversion or undiversion. So what are the recommendations of EAU? Perform bladder augmentation in order to treat refractory neurogenic detrusor overactivity cases, a strong rating. Place an autologous urethral sling in female patients with neurogenic stress, urinary incontinence who are able to self-catheterize, again a strong rating. Insert an artificial urinary sphincter in male patients with neurogenic stress urinary incontinence, again as a strong rating. So these are the grade of various things used. Detrusor overactivity, detrusor myoemectomy is a grade B evidence. Sacral rhizotomy, again grade B. Bladder augmentation, grade B recommendation. In case of underactive bladder, sacral rhizotomy with sacral neuromodulation are effective in selected patients. Grade B evidence. If it is the urethral problem, if it is detrusor sphincter dyssynergia, that's as told in the guidelines earlier, if it is an underactive bladder, underactive sphincter, we can try using a urethral sling, which is an established procedure, and artificial urinary sphincter is very effective. These two have got grade B evidence. So urinary tract infections in neurourologic patients, EUA recommendations are: do not screen for or treat asymptomatic bacteriuria in patients with neurourological disorders. This has a strong rating. Avoid the use of long-term antibiotics for recurrent urinary tract infections, a strong rating. In patients with recurrent UTI, optimize treatment of neurourological symptoms and remove foreign bodies like stones, indwelling catheters from the urinary tract, strong rating. Individualize the patient's UTI prophylaxis in patients with neurourological disorders. There is no optimal prophylactic measures available. Again, this has a strong rating. So, in regard to male erectile dysfunction, recommendations are: prescribe oral phosphodiesterase 5 inhibitors as the first line modality. Strength of rating is very strong. Give intravenous cavernous injections of vasoactive drugs alone or in combination as the second line treatment in neurogenic erectile dysfunction, as a strong rating. Offer mechanical devices such as vacuum devices and rings to patients with neurogenic erectile dysfunction, again as a strong rating. Perform vibrostimulation and transrectal electroejaculation for sperm retrieval in men with spinal cord injury patients, as a strong rating. Perform microsurgical epididymal sperm aspiration, testicular sperm extraction and intracytoplasmic sperm injection after failed vibrostimulation, or transrectal electroejaculation in men with spinal cord injury, strong rating. Counsel men with spinal cord injury at or above thoracic 6 level and fertility clinics about the potentially life-threatening condition of autonomic dysreflexia, again as a strong rating. Again, regarding female sexuality and female fertility, do not offer medical therapy for the treatment of neurogenic sexual dysfunction in women, strong rating. Take a multidisciplinary approach tailored to individual patient needs and preferences in the management of fertility, pregnancy and delivery in women with neurological diseases, again as a strong rating. What is the recommendation regarding the follow-up? Assess the upper urinary tract at regular intervals in high-risk patients, strong rating. Perform a physical examination and urine laboratory every year in high-risk patients, as a strong rating. Any significant clinical changes should instigate further specialized investigation, and perform urodynamic investigation as a mandatory baseline diagnostic intervention in high-risk patients at regular intervals. This has got a strong rating. So to conclude, neurourological disorders have a multifaceted pathology, require an extensive and specific diagnosis before one embarks on an individualized therapy, which takes into account the medical and physical condition of the patient and the patient's expectations about the future. Urologists can select from a wealth of therapeutic options, each with its own pros and cons. Guidelines offer expert advice on how to define the patient's neurological symptoms as precisely as possible and how to select, together with the patient, the appropriate therapy. Last choice, as always, is given by the golden rule: as effective as needed, as non-invasive as possible. Thank you.
Thank you very much, Dr. Rajiv. We will have all the discussion in the case presentation session. In the next session, we are a little behind schedule. Is that okay, Dr. Chawla?
Thank you, Chairperson.